Welcome aboard again, the EGVRS tour around the retina world in 30 days. In this tour, we will get to meet the stars of vitreoretinal surgery around the world. We will get to know more about their personal life, their success stories, their dreams, and more. And for 30 days, we will roam Mother Earth, exploring the retina world around us, communicating and learning from each other, not only about the retina and vitreoretinal surgery, but also about the wisdom of life. Our stop today will be in Asia. So we shall land in Osaka, Japan, where we are going to meet Professor Dr. Shunji Kusaka, Professor of Ophthalmology, Kindai University, Faculty of Medicine, Osaka. Professor Shunji is a renowned world expert in pediatric retinal disorders with more than 190 international publications, a frequent guest of many international retina meetings, and above all, a friend of the Egyptian Vitreoretinal Society. Dr. Shunji is an excellent vitreoretinal surgeon, and we have witnessed and watched him operate during the live surgery session at the last EGVRS meeting in 2019. Welcome, Professor Kusaka.
Thank you. Thank you very much for kind introduction, and thank you very much for having me for such a extraordinary, fantastic event. I'm Shunji Kusaka from Osaka, Japan. Very nice to see you all in Egypt.
Well, thank you for accepting our invitation, Shunji. Let me ask you some personal questions to get to know you.
Sure.
Are you one of a family of doctors, or you're a loner?
No, now my family are doctors. So I grew up, my father is just an ordinary company employee, and my mother is a school teacher of elementary school. So there is no, it's not so rare to be a doctor from such a family. But I was thinking what stimulated me to be a doctor. But when I was 10 years old or 11 years old, I grew up in a very rural area in Japan, very small village. There was a internal medicine private practitioner nearby. He was very nice, and he seems to be helping many people. So that seeing him, that I wanted to be like him. So
he influenced your your direction.
Yes.
But I mean, okay, so you went into medicine. Where did you go into medicine? In Osaka or Tokyo?
Yes, in Osaka.
Osaka. And
I entered Osaka University, which is one of the 7 imperial university in Japan.
But okay, so but how did you end up in ophthalmology, and why?
I wanted to do, I was very interested in doing surgery. So there, whether I want to be a heart surgeon or ophthalmology or ENT, that's the question I asked to myself at, when I, just before graduation. But I wanted to be a heart surgeon, seriously, but they told me, there are some seniors in that department. They told me that after spending 20 years working like a resident, 1 of 10 doctors can do heart surgery at that time.
No, this is very tough.
Yeah. So the probability to be a heart surgeon after 20 years is just 10%. So
Well,
I gave up.
so well, we're lucky that you
Yeah.
ended up choosing ophthalmology. But okay, so you became an ophthalmologist, but how did you end up actually going into the retina and vitreoretinal surgery?
Yeah, when I was a resident, I was like rotating many subspecialties, glaucoma, retina, and cornea. And after one rotation, I noted that the retina surgeon can spend most of the time or more time in the OR. That's what I want to do. And
So
yeah,
you are actually in love with the OR.
yeah, I like being in OR. So the retina surgeon. And at that time, the vitrectomy was it was the beginning of the modern vitrectomy. There are a lot of things to be to develop at that time. Totally different from nowadays. Nowadays, the techniques are some of the techniques are complete. It's hard to develop something new, but at that time, everything you do in the OR looks like new to me. So it was a very exciting field.
That's
And
true. I mean, our generation witnessed
mhm,
huge developments and huge changes
yeah.
in the instrumentation, the
Mhm,
technology, and everything. Yeah, yeah. Okay, tell us about the practice of ophthalmology in Japan. I mean,
mhm.
you have private practice. Is it only in the university? What is the practice like?
Yeah, we have university hospital and like a public hospital, municipal hospital, or some other private hospital, and private practitioner. Private practitioner tend to practice alone, most of private practitioners. And some private practitioners own a small hospital and hire some ophthalmologists, but it's relatively uncommon to practice like that. So about more than half of people, ophthalmologists run private practice, and less than half, let's say 40 to 50% of doctors are working at the hospital. We the uh, actually we don't have private patient. Uh, Virtually all the Japanese people are covered by national insurance. So whether you are in the private practice or in the university, the patient are covered by national insurance.
Okay, yeah.
If
So
you are, yeah.
yeah, yeah. Okay, let's go into a very important
Mhm,
time or a very strange time we're working in during the COVID-19 era. And
mhm.
the last 2 years were very different and very stressful. I mean, how did the COVID-19 pandemic affect the practice in Japan?
Yeah, in in my university, Kindai University, we accepted the only patient with serious conditions. But to accept 10 to 20 serious condition COVID-19 patient, the nurses, there are a lot of nurses and doctors are necessary. So some part of the operation need to be canceled, like cataract surgery or strabismus surgery had to be canceled. So the number of cases we can do in a year reduced about 10 to 20%. But we could do retina surgery, like retinal detachment. But most of the retina surgery could be done without any restriction. Yeah.
Well, okay. So, well, the COVID-19 affected all of us, well,
Yeah.
I must say. I mean, let's go into another interesting and rather light thing. What's your favorite food and what's your favorite country?
Oh, favorite food is I like Japanese food. Yeah, of course, I like sushi and fresh fish raw fish. Probably you don't like it, but
No,
I
I
like
love it. I
very.
love it. I
Oh,
love
you
it.
love it? Great.
Yeah.
Yeah, I like fresh tuna or salmon and every Japanese food. And I also like some steak. I like French, Italian food.
Did you
And
like the
yeah,
Egyptian food when you were here?
yeah, very much. Yeah, it, I
Very good.
enjoyed Egyptian food very much. Yeah, it's so nice.
So, what's your favorite country? You've been all
Country.
around the world.
Yeah, many countries. Like, of course, Egypt is one of my favorite country with rich histories, with unbelievable pyramid and historical monument. Many things I was so surprised to see, and people are very nice. So Egypt is without doubt one of my favorite countries. And many countries in Europe, like UK or France or Germany or America. I like America very much. Not all aspect of America, but some aspect of America I like very much. Probably you would agree.
Yeah, I agree. Okay, so thank you, Shunji. Now that we've really got to know Shunji Kusaka, his background, his what he likes and his studies, and what he studied, and how he came into ophthalmology. Now we'll take a pause, a short break, and we'll be back with you with the second part of this episode, which is the scientific part. Again with our dear guest, Dr. Shunji Kusaka from Osaka, Japan. And Dr. Kusaka is going to present to us a very interesting topic about morning glory syndrome. Please, Dr. Kusaka.
Yes, thank you for introduction. I'm going to share with you today the recurrent severe PBL seen in eye with morning glory syndrome. Morning glory syndrome is a congenital optic disc anomaly caused by abnormal closure of the embryonic fissura with outward herniation of the disc and peripapillary tissues. It was first described by Kindra and Ellsworth in 1970. The retinal detachment, either regmatogenous or non-regmatogenous, are seen in about 1/3 of the cases with 10 years follow-up. This patient is a 6-year-old boy with a normal eye in the right eye with good visual acuity, but as you can see in the left eye, total retinal detachment was seen. His visual acuity was 0.05. The reattachment of the retina in an eye with morning glory syndrome is difficult. We decided to wait for 1 month to this spontaneous reattachment. However, the retinal detachment became worse, so we decided to go in. So after creation of posterior vitreous detachment, now you can see in this area a break within the excavation, which can be clearly seen by intraoperative OCT. So after fluid exchange, subretinal fluid was aspirated through this break, and laser photocoagulation was performed to, around the excavation to block the communication between the subretinal space and the vitreous cavity. I thought that surgery was successful, but 10 days later, 3 weeks later, the patient came back. This patient lived somewhere remote, but so he couldn't come regularly after the surgery. After 3 weeks, he came back with retinal detachment. The lens was opacified at this point, so it was removed with the implantation of IOL. As you can see here, the PBR developed. Subretinal strand was removed from intentional hole, and the membrane on the retina were removed as much as possible. After fluid exchange, the laser was performed again around the retinal break. I thought again the surgery was successful. But 2 months after the surgery, patient came back with dense fibrin formation on and behind the retina, behind the IOL, with the development of severe PVR, as you can see here. So the lens was extracted, and as you can see here, there's a severe anterior PVR. So the peripheral retinotomy was performed, followed by the removal of the epiretinal membranes and the membrane behind the retina. 360 retinotomy was necessary to reattach the retina. This is a view of the excavation. So PFO was injected, followed by laser photocoagulation in the peripheral retina. In this case, purple carbon liquid was retained after the surgery for 10 days to reattach the retina. This is a technique which I sometimes use for pediatric difficult cases. But I was very surprised to see when I tried to remove PFO 10 days after the surgery, the retina is flipped over to the superior direction under the purple carbon liquid. I have never seen such retinal configuration under purple carbon liquid. I was completely shocked to see this, and I was not sure what caused this kind of weird retinal configuration. Anyway, I opened up the retina again and injected silicone oil this time. And we tried to remove silicone oil 1 month after the surgery, but the patient strongly refused to go to the OR at that time. And we noted that patient shakes his head very much rapidly and vigorously. By the way, this patient had some intellectual disability, so-called Asperger's syndrome. He couldn't sit still on the chair for, let's say, 10 seconds. He moves around. And before surgery and after surgery, every time he cries, right, with shaking head very much. So we had to wait 4 more months, and I noticed under the silicone oil, the retina was flipped over again to the, this time, temporal side. So severe proliferative response was seen in this patient. I wondered why. because he had ADHD, or let's say politically correctness word is intellectual disability these days. Whenever he cries, he shakes his head very rapidly and vigorously. And so we thought that excessive head shaking might be the cause of redetachment and proliferative response for this patient. Pediatric patients tend to show a strong inflammatory and proliferative response after the surgery, but the funnel-shaped detached retina flipped over to one direction is what I have never seen before. So not only postoperative positioning, but also postoperative resting for a while seems to be critical for good anatomical success. So fortunately, this case has been published in American Journal of Ophthalmology case report. So if you are interested in, so please look at our literature. Thank you very much.
Thank you very much, Chunji, for the very interesting case. I mean, it's not only interesting, it's very challenging. And the problem with these cases as well is they are very rare. So you don't actually have cumulative experience in handling them. So it's always, each case is a challenge in itself. And this poses some questions. One thing, I mean, do you use special instruments when you are operating on these patients? Because usually they are myopes with a very deep excavation. And sometimes your regular instruments are not enough. What do you do?
Actually, I didn't use very elongated forceps because I didn't have to manipulate inside the excavation. So what I did was this patient had I don't remember exactly, but the axial length was 24 or 25, not very myopic. So, for this particular case, I used normal. I used probably 25 gauge vitrectomy instrument, not special ones.
Okay, you in this patient, you actually managed to find a break at the rim of the excavation, but sometimes you don't find a break, and it's very difficult to find a break. So what do you do?
Yeah, that's a very good question. That's what I wanted to ask you. But sometimes, as you mentioned, that the excavation, when the excavation is so big, you cannot see inside the excavation. There must be some break inside the excavation, but you cannot see. So in that case, I use external drainage of subretinal fluid, like you do in scleral buckling procedure. And after that, you can apply laser around the excavation. But such cases is sometimes difficult to treat.
Yes, that's true. Another question, I mean, there is in the excavation some retinal tissue inside the excavation, and sometimes you're faced with a fibrous plug inside the excavation. I mean, do you make it a point to remove this fibrous plug during surgery? That's
you mean on the disc, right?
Yes.
Or disc excavation. Yeah,
Yeah.
I try to remove it, but it sticks so hard to the disc. So I never succeeded in removing the I don't know how to call it, but Bergmeister something. Yeah.
Yeah, it's a remnant of the membrane or the vitreous.
Yeah, it's very hard to remove.
There had been some concerns about using PFCL or perfluorocarbon in these cases because of the possibility that this might go through and end up in the subretinal space, or sometimes even the subarachnoid space. What do you think about, did it happen to you?
I completely agree with you. probably you should avoid using purple carbon liquid or even silicone oil in these cases with morning glory syndrome or optic disc bit micropathy or coloboma cases. So as you mentioned, these substances might migrate into the subretinal space or subarachnoid space. So my first choice is to use gas in almost every case, first step. But in this case, it didn't work twice. So I discussed with the parent that this might be the only way to reattach the retina. So patient agreed, and they were aware of the risk of the herniation. But yeah, unfortunately, this patient, because the retina was detached anyway after the surgery, I didn't see the migration of the retinal fluid. But different from this case, I experienced migration of purple carbon liquid in the subretinal space intraoperatively, what I have seen. So,
Yeah.
so
It is a problem. It is a problem.
Yeah, I would recommend using gas.
Yeah. One last question, which is, I'm sure that we have to ask ourselves really about the validity, because this is usually a unilateral condition. And the eye is amblyopic. In most of the cases, this is a weak eye. And the question which poses itself, should we end up operating on these cases? Yes or no? I know that it is a difficult question to really answer, but provided the complications we meet, the poor results of surgery, what do you think?
Yeah, that's a very good and very tough question. I always ask myself whether I should do surgery for this case. And I spend a lot of time with the parents, what would be expected for natural cause and what would be expected after surgery. My success rate for this type of retinal detachment is around 50%. That's very bad. The remaining 50% is the retina could not be reattached. So, and Dr. Haik in the US reported that I mentioned in my presentation that there were 11 eyes he observed, 11 eyes of retinal detachment he observed for a long term. 4 of them reattached spontaneously. And two of the 4 eyes redetached spontaneously after that. So yeah.
Maybe we should go, if you want to give the patient a chance, we have one go, and if it fails, we leave the eye alone. Maybe this is a much logical way, because I must say that those children get traumatized with the repeated surgery, and they have a real trauma. Dr. Shunji Kosaka, it has been a pleasure having you with us, and thank you very much for sharing with us this challenging and difficult case.
Thank you very much.
Difficult situation. And
I enjoyed very much.
We really hope to see you. The pandemic has posed a lot of problems in us meeting each other, but I hope that the pandemic will end up and that the war we're witnessing now will not hinder future meetings to see our friends. Thank you very much, Dr. Shunji.
Thank you very much. Thank you very much for having me.
Pleasure.